So, as promised, let's run those two words down I mentioned that were symptomatic, or yeah, there's the symptoms of cirrhosis. They're also manifestations of cirrhosis. And the two words were jaundice and ascites. So here we have jaundice, and a picture illustrates it pretty well. This is a yellow discoloration of the skin, mucous membranes, and sclera of the eyes. It's caused by excessive levels of bilirubin in the blood, and this is known as hyperbilirubemia. Try saying that one 3 times fast. I'm amazed I got through it once. I'll try it again. Hyperbilirubin. Yeah, see, I shouldn't have done it. I got it the first time. So excessive levels of bilirubin are the result for this discoloration in these organs. Liver disease, hemolysis, obstruction of bile ducts can cause it. We're relating it directly to liver disease in the form of cirrhosis. And so you have bilirubin in the blood, and it's something that is a byproduct of part of our metabolism. If those levels build up too much, you see this yellow discoloration. If you've ever seen a patient who has jaundice, it's unmistakable. You will recognize it right away. And if it's profound jaundice, their eyes will be, and the scleras will just be bright yellow. So you're looking at someone who's likely in liver failure if you see that. Well, I shouldn't say likely. They are in liver failure. You may not know if it's acute or chronic. So it might be just another episode of their hep C acting up, and it might be the beginning of end-stage liver disease. Without knowing their case, you're not going to have that information. But you'll see it on them. You'll see that yellow skin and those yellow eyes, and you'll understand that that is jaundice. And the other thing that happens as organs begin to shut down is ascites. So it's this abnormal accumulation of fluid in the abdomen. This occurs naturally when people go through deaths and prolonged deaths, like of cancer. For instance, my mother, when she died of cancer, she had ascites, and she was a small woman, but her abdomen swelled up to the size, it looked like she had triplets. It was simply interstitial fluid of the organs as they began to shut down would simply fill the abdominal cavity. The peritoneum would just be completely maxed out with fluid. They can do a procedure to try to relieve it. Generally, although not always, generally ascites is signs of an end-stage disease. Although I have seen patients who've had acute ascites. They had the procedure I'm about to tell you about and had it a few times, and whatever disease they were suffering from, it resolved at some point. But in my personal experience, and generally speaking, people who are in end-stage kidney failure, renal failure, something like that, dying of cancer, ascites is very common, and it's an indicator that that their eventual passing is close, I guess would be the way to put it. So paracentesis, otherwise known as abdominocentesis, is a possibility here. Once again, our surgical puncture, right? Because we want to make sure that we don't put any pathogens in that abdominal cavity. So this is a surgical puncture to remove fluid from the abdominal cavity, very much like the thoracentesis I showed you in the respiratory chapter. Same concept, except they're going straight into the stomach. They don't have to worry about getting too close to any nerves like you would in the back when you're doing thoracentesis, and you don't have to worry about going between ribs because they're going right into the abdominal cavity. So once again, this is usually palliative, which means it's making the patient comfortable. It's not going to cure anything, but it takes that pressure off their abdomen and gives them a lot of relief. So it's an act of mercy, I guess. And the people, especially hospice nurses, are very good at knowing how to do this procedure. Okay, so now we're going to use our word that we've learned before. One of them, actually. Yeah, we have one of them here. That means blood, and that's the second word here. We're going to start with emesis, which is our suffix for vomiting. Hyperemesis is excessive vomiting, and hematemesis is vomiting blood. That was a tough one to get out. Sorry about choking on that the first time around. Hematemesis is vomiting blood, and these little containers down here are known as emesis basins, and they're about an inch deep and about 4 inches long, and they are not something you give to someone if they're about to vomit. Thankfully, modern medicine is caught up, and now in the hospital we have these bags that are quite long, look more like a bread sack, and they fit over your mouth. More appropriate for hyperemesis, because believe me, I've given these to patients before and ends up not being so effective at collecting what's coming out of their stomach. So if you see those around, they're great for organizing drawers. They're not so great for patient care. However, if it's all you got, you use it. And let's say your patient's in that situation, and your doctor comes out and says, we're going to go ahead and administer an antiemetic, and they give you the order for it. That means you're about to administer a drug used to treat nausea and vomiting. So we see some illustrations of it here on the left and in the middle. Zofran is probably the most common antiemetic. We use this in clinical setting. And you see next to it promethazine, which is another form of antiemetic that we use, and that's in the form of suppository. And of course, we do this by injection or suppository because if we give it to you as an oral medication and you're already nauseated, you might throw up the medication before it has a chance to work. The side that you have to remember about Zofran and using promethazine is that they can cause drowsiness. So if it's administered to a patient, it's a very good idea to make sure that they have a driver to take them home. Most doctors will clear that before they give you the order. And those of you who learn to be MAs and nurses will learn your protocols, and likely you're going to come in and ask the patient, do you have someone who can take you home before I give you this medication? Having said that, when you're severely nauseated, this is a great drug to relieve all of the symptoms. It just takes it out just like that. All right, so moving on. An accessory organ to the liver is the gallbladder. The gallbladder stores bile that's been made by the liver, and then it delivers that bile into the stomach via the common bile duct. It's close to the head of the pancreas and over by the duodenum, which is the beginning of the small intestine. And it delivers that to the stomach via ducts that are in that area. So they kind of bypass the pancreas. They go, in some cases, to the duodenum, and the gallbladder will then release these digestive juices to help break down food. As we know, the gallbladder can also be problematic for different types of inflammation and stones. So the combining form is cholecyst, and that's how we refer to a gallbladder. And cholecystitis would be inflammation of the gallbladder. So that's a common affliction if you have stones or some other pathology of the gallbladder. And that's going to be, by the way, right upper quadrant pain. So the patient comes in, says it's right upper quadrant pain. It's not super deep, but it's not superficial. It's kind of in the middle. And your thought should go right to possibly a gallbladder. And then we have certain blood tests we would run to check for different types of enzymes to see if those are present and in what quantity. And based on that, the doctor might make a diagnosis of that gallbladder. So staying with that cholecysto, rather, the combining form for gallbladder, we have a cholecystogram. It's an X-ray of the gallbladder. Cholecystolith would be a stone in the gallbladder, and a cholecystectomy would be excision of the gallbladder. Sometimes gallbladders will get very problematic, and they can remove them. Now, they're not absolutely needed. They are an accessory organ. However, those who have the cholecystectomy will eventually have to change their diet to a very low-fat diet because their body won't process fats very well after having the gallbladder removed. Having said that, it relieves a lot of symptoms to have it removed for some folks, so it makes perfect sense. You're seeing two different types of surgery depicted here. The one on the right is the old open cavity surgery that we don't do very much anymore. Surgeons now usually will do surgery a different way. They'll do it with a technique called laparoscopic. And in that one, they use usually 3, now this depicts 4 different types of instruments that enter the body in small incisions. And using those instruments, they can go in and they can find the gallbladder. One's a scope, of course, one cuts, and there's various applications to each of these appliances you see here. And without putting a big incision in the patient, by using these small incisions, they can remove that gallbladder. And it's no open cavity surgery, so no open abdominal surgery, which means infection risk goes down a lot. Recovery time goes up. So, pardon me, recovery time goes down as well. You recover quicker is what I mean to say. So I misspoke on that one. So laparoscopic is the way that surgeons prefer to do this now. Open abdominal, not as likely, although they are still performed. And sometimes they're necessary. Now, if we talk about the substance that the gallbladder makes, it's known as bile or gall. And that has its own combining form, chola. So cholelith is a gallstone. So they're saying basically a gallstone, literally using the word gall. And gall is just another word for bile. So it's one of the digestive enzymes or acids that we have that break food down. If you have a condition of presence or formation of gallstones, you have cholelithiasis, and that's what you're seeing here. So this is a dissected gallbladder that has stones, and you can see the stones present in there. It's basically dysfunctional at this point, so they would do a cholecystectomy, completely remove it. Then, of course, they're going to biopsy it, and they probably took the photograph during the biopsy when they cut it open to see what the stones look like. So there's a few more gallbladder terms. And there's another technique they can use to get rid of stones as well. It's called lithotripsy. So they take litho. Now, I know that was a suffix earlier, but guess what? Now it's a combining form. So your eyes are not playing tricks on you, and I'm not playing tricks on you. It's a for real combining form. Litho for stone, and we use the suffix tripsy, that means crushing. We put it together, we have lithotripsy, a surgical crushing of a stone, usually within the gallbladder or urinary system. So when they say surgical, it isn't exactly like they're going to go in and do an operation. As a matter of fact, it's done one of two ways. I've seen it done in the pancreas using a device that looked like a very long syringe, and it was threaded through the patient's esophagus, down through the stomach, and then back up into with the pancreatic duct. And the doctor was able to hit a lever that released basically like a hammer on the other end, and it just crushed the stone. And we watched all of this on an endoscope that was inside the patient's pancreas at the time. And then they removed the stone piece by piece because it was too large to pull out as one piece. So that was a form of lithotripsy. That was mechanical lithotripsy. And often that's necessary to do, especially for things like pancreatic stones, which is the case I was just talking to you about. It was very interesting to see all that happen. There's another form. I've never seen this form happen, but I have had an ultrasound tech describe it to me. So this is called extracorporeal shockwave lithotripsy. Keep in mind, they're showing you a kidney here, which is not part of the GI tract. So that might be a bit confusing. The reason they're showing it is this type of shockwave lithotripsy is done with an ultrasound and very commonly done on the liver. Although I do understand it can be done on gallstones as well. So in extracorporeal shockwave lithotripsy, it's a non-invasive method, and it uses shock waves via ultrasound to destroy stones in the gallbladder and bile ducts. I've never had it done. I've never witnessed it being done. Doctors and patients alike prefer it because it's not invasive and there's no surgery involved. I have heard, though, that one is quite sore in that spot for a few days afterwards because it's a very strong ultrasound wave they're using. However, if it gets rid of the stone and cures your symptoms, short-term pain, long-term gain, right? And we always have to put that on the scale of medicine. What's the risk? What's the benefit? And how prominent is the benefit? Is it really worth the risk? In this case, a few days or a week or two of soreness versus you get rid of those kidney stones and keep your kidneys, or gallstones and keep your gallbladder. I'll go for this couple of days of soreness personally. Mentioned the pancreas before. It's actually an endocrine organ. It's not part of the digestive tract. However, it does produce something we really need a lot of, which is insulin. And when it fails to produce insulin, we have something called diabetes. So it's an accessory organ. It's located directly beneath the stomach. The beginning of the small intestine you see wraps right around it. And at the top portion, you see the gallbladder, which is tucked underneath and behind the liver. So that's essentially the pancreas. Pancreatic means pertaining to the pancreas. Pancreatitis is inflammation of the pancreas. This is something we often see in alcoholics and sometimes in severe diabetics. Pancreatolith is a stone in the pancreas, and I just described that to you earlier. The surgeon I was talking about had inserted the scope and the device to break the stone down through the common bile duct, which you see up here in the corner, and it descended down into the pancreas. And so we were able to view through a camera lens the inside of the pancreas, and the whole organ, of course, was lit up, and then the destruction of the stone, and then removing it through the common bile duct. It was pretty cool. And God forbid we have to remove the pancreas. It's a pancreatectomy, excision of the pancreas, which does happen in certain cases. Pancreas is known for one of the sneakiest cancers out there. It's usually a silent cancer. If you've ever known anyone who's had pancreatic cancer, they probably didn't have a very long time between, from diagnosis to prognosis manifestation, essentially. My mother-in-law died of pancreatic cancer. It was advanced. She was a pharmacist, worked in medicine. She knew the signs and symptoms, but this tends to be a silent cancer. For her, the symptoms manifested all at once, and she was given a matter of months. I've heard of people getting a matter of weeks on pancreatic cancer. However, there's a flip side. New therapies that have come out in the past 3 or 4 years are showing people are living 5, 6, 10 years of pancreatic cancer. They're far outliving the prognosis by decades in some cases. So it's not all lost. It is a cancer, of course, we want to avoid, but there are treatments for it. I'm going to pause it there and come back to you in just a moment with the lower GI tract.